That was a wonderful panel. We have a lot of interest in questions, so we'll start on the right. Please introduce yourself and ask your question.
Good morning. My name is Urmimala Sarkar. I'm a professor at the University of California in San Francisco. I'll be speaking tomorrow. But today I just want to take off my cancer communication expert hat for a minute and speak from two vantage points very briefly. First, I have a general observation, which is that we've talked a lot about this morning about training. I do a lot of work in patient safety, and when we do root cause analyses, we look at our corrective actions, and some of those actions are in the space of changing people's work responsibilities, changing policies, and one common intervention is training. And I can tell you that for decades in patient safety, it is received and understood knowledge that training is a weak intervention for changing behavior. So I just want to put that out there, that I think we need to remember that in health literacy and communication broadly, training is necessary but not sufficient. The other question I have, or observation I have, is for Dr. O'Connor in particular. So I have to say that your pyramid of training made me kind of sad, because it's very oncology focused. I'm a primary care physician. I take care of people with complex chronic conditions at a public medical center, Zuckerberg San Francisco General. We do not take any insurance, so my patients are very diverse and very low income. Their access to oncology is pretty limited. And so, like many primary care physicians, I have had communication training. I am deeply invested in end-of-life planning with my patients. And I think it is short-sighted to have only oncologists on your pyramid. It also does not account for the oncology care shortage more broadly that is disproportionately affecting low-income patients in this country. So I would challenge you to include primary care in your paradigm of how you think about this.
Thank you so much for both those comments. And I should say this is the oncology version of the pyramid that I brought specifically to this forum. However, that pyramid is really a much broader health system strategy, and we're doing very similar work in our primary care service line. And so I very much think they're an important part of the continuum. And absolutely, the pyramid you could reproduce for cardiology, primary care, really all of the healthcare system. I also agree with you that I think training alone is insufficient. So we also really have to think about what are the systems of care that support the training? How do we provide reminders? How do we help identify the patients? How do we track the patients? Absolutely. Thank you.
I think we should have one pyramid, and primary care should always be in. I don't think there's any paradigm that shouldn't include primary care. And now I'm professional.
I'd just like to add to the training. I also agree that the training needs to be coupled with systems intervention. I would point out that many of those patient safety training things before actually were weak training interventions, and so I do think there's something there. But clearly, the team is needed the team of both components is needed.
Yeah. Hi. Weijin Ko from NCC, and I promised Dr. Bach a couple of tough questions. So this is for him and the rest of the panelists. Thank you very much for your presentations. I want to ask a couple of questions about repetition and reinforcement. So there's a tendency as healthcare providers, educators, researchers, for us to think in sort of a temporally linear or process linear way. And we want to sort of say the patient is sufficiently educated or informed. But what about repetition? Because we perhaps maybe not appreciate that we need to introduce new elements as we go along. We talked about multiple facets, or in fact discuss the same thing over again because their understanding changes. So that's number one, that perhaps we cannot declare mission accomplished. We need to go back and revisit the same things again. The second one about reinforcement, and this is perhaps most germane to prevention, is do we need to learn something from behavioral economics? I mean, behavioral economics tells us that people appreciate loss more than they appreciate gain. So if we tell patients that they need to do something to assure a better future, but they say, I'm going to take a day off from work, I'm going to lose pay, it's going to be inconvenient. How can we incentivize and reinforce at the present time as opposed to you're going to live 10, 15 years longer in a healthy way for the asymptomatic patient?
Yes, Dr. Koch, two terrific questions. And since there's a long line, I am going to be right to the point. The first issue about how patients' understanding changes, I totally agree with you. And as an expert clinician, you have seen this many times as well. To me, it's the reason that we need the whole team able to participate in these conversations. So in fact, the whole team can be kind of an early warning system about when something surfaces that clearly needs some reinforcement or rediscussion. And I feel like that's part of what great clinicians ought to be doing every time they interact with a patient, is that they are at some level checking understanding and providing, targeted reinforcement. The second thing about your comment about behavioral economics is quite interesting. I totally agree that the evidence to date suggests that patients are more sensitive to losses. And yet we also have, I think, a counter experience in the space of palliative care, which is that patients are terrified to talk about dying. And bringing up the most stressful thing at the very beginning is, I think, a practice that we have to be very careful about. I think this is often based on a paradigm of communication that says, I deliver messages as a clinician, that's what my job is, when actually my job is really, I establish the dialogue and keep people engaged so that they can eventually get to the really tough questions. So I think the issue in terms of how this works, in terms of the behavioral economics findings, I think is an unresolved one scientifically, but very interesting.
Thank you.
And I just wanted to add, I think what this really highlights is this engagement of patients and families, that things are not linear, but they change based upon nuances, about new information that may come to bear, and people can look at things differently. So it reinforces, I think, one of the major tenets today is creating those relationships. I remember years ago, one of the trainings, and this was a long time ago, is really to look at the content that wants to be delivered and somehow include individuals, and then the trust has to be there to make this whole three-step process actually work. And so that process doesn't just stop with one conversation that I have with you, but is going to change based upon new information. So great points.
Thank you. Next, please.
Hi, David Goldstein from the CMS Innovation Center. I just wanted to say thank you to everyone. I've learned so much valuable information. I work in the oncology space at the Innovation Center, and I think this question is for Dr. Penedo. Regarding patient-reported outcomes, so the Innovation Center tries a lot to incorporate patient-reported outcomes into what we do. And there's a trend for electronic patient-reported outcomes. I know that you spoke a lot about that. Sometimes they're in the waiting room, sometimes they're in the clinic as the clinician is there. And I was curious if you could talk quickly, I know there's a lot of others who would like to ask a question, about what that flow looks like after you take the information. Since it's not just about improving the way that we communicate, it's also about how we use that information to improve the quality of care. And so I know that that's an emerging area, and I'd love to hear your thoughts on that.
So that's an excellent question. So we have several domains. So for the depression, anxiety, and physical symptoms, those are promise measures, and we have a threshold that said to launch an alert if the patient has a clinically elevated level, let's say, of depression or fatigue. If it's anxiety or depression or a practical need, like need of transportation and childcare, the alert goes in real time to social work. If it's more along a physical symptom or a medical need, the alerts go to the nursing pool. The provider has to respond to that alert within 72 hours, and there has to be a documented disposition within the EHR of what did they do with that alert. It could be the patient's already being seen for depression, or it could be the patient was referred to psychology or supportive oncology services. But all that is being tracked in the EMR now.
I think it's a really good point, because I think the question is more information may not always be the answer. And the thing that I am thinking of as I listen to the panel is, what is the bandwidth of a patient at any one moment in their trajectory, and what's the most important thing for us to bring to the forward? And I think it's the same for the providers. Oncology providers, they're doing 3 hours of documentation every night, and looking at another panel of alerts, I'm worried about that, to be honest.
If I may respond to that, so the alerts for depression and anxiety tend to be maybe 7%, 8% of our patients, mostly because these are patients across the entire continuum. Many of them are post-treatment or they're already under care. For the physical needs, it's even less. So, but I completely agree with you. Actually, there was a recent study coming out about physician burden and electronic health records and alerts and messaging related to patient screening was one of the main concerns they had. It's a very good point.
I think that speaks to being a highly functioning team where communication is accurate, timely, gets to the right people, and you've got systems in place that share the work. But Dr. Wender.
Hi, Rich Wender from the American Cancer Society. Very quick comments. I really appreciate the emphasis on palliative care. I think we need to act more urgently, even though perhaps we're urgent, as we face in the next decade the baby boomers being in their 80s and not in their 70s, and the implications are just enormous if we don't change our approach. And as a former participant in Vital Talk, there's training, and then there's amazing training. And amazing training can really have an impact. So appreciate that. My question is about fight language. I don't think the word fighting cancer is going to go away. It's incredibly empowering for some. They use it, they rely on it, but devastatingly hurtful for others. And Macmillan in England is using fight for your best day. So is there a way for us to re-channel fight language, or any specific suggestions? And anyone who has an opinion, I'd welcome.
I think you're right. I don't think fight is going away, and for many people it is powerful. I think we have to be careful whether we're giving them fight language, though, or whether they're giving us fight language. We should never be the one giving them fight language. So that's the first point. But then if they're using fight language, what is the language they can accept that allows a conversation that isn't instead of fighting? It's, while we're fighting your cancer, I just want to make sure that I understand your plan B. Sometimes I use plan B. Or while we're fighting your cancer, I want to make sure I understand what would be important to you if things don't go as we're both hoping, knowing that I'm going to do everything I can in my power to help you live as long and well as possible. So you have to create an ability for those two things to exist at the same time. It's possible to fight and to plan. And I think that's really the key. And I may have other thoughts, but...
Well, in addition, it's sometimes changing the focus of what you're fighting for. If fighting is the metaphor, fighting is the language, fighting is the mindset. We may not be fighting for a cure, but we're fighting for quality of life, those sorts of things, and a little shifting.
The point I would just ask us to remember, though, is that for many people, living with cancer is a struggle. And I think one of the things that they are reflecting in that comment about fighting is their underlying struggle. And I think it's important we may be careful about what language we choose to reinforce, but being seen for the struggle that you are participating in, I think is the underneath part of that comment.
Yeah, thank you very much.
Thanks. Thank you. Next.
Thank you for a wonderful panel to consider so many important communication issues facing cancer care. I'm Sylvia Cho from the National Cancer Institute. One thing I've heard is this traditional model of health literacy focuses on clear communication. How can we be better at sort of messaging? But I also hear that part of patient-centered cancer care is helping people manage uncertainty, and cancer brings so much uncertainty, whether it's thinking about fertility, thinking about using of genetic testing, or cultural and religious considerations, as well as prognosis and goal of care communication. I've heard uncertainty being used by physicians dealing with people who are very sick as a way to talk about your treatment may not work for you. But I also hear that as a way to not get at some of the issues that are really facing, it's like just using uncertainty. Whereas I think uncertainty is important. It's never going to go away. So I'm just curious about sort of the panelists' thought of whether we're thinking of this as a dichotomy, or is it a conflict? We're trying to communicate clearly. Should we delineate where is an important part of consideration and where we should be using the language of uncertainty? So, thank you.
Dr. Back? Dr. Quinn?
Yeah, I'll just comment briefly about that. I think patients often can't accept that the expert is uncertain. I think they expect definitiveness. I think it takes away from their safety and security. But the reality is, I can't think of anything that we can say definitively except as they say death and taxes. We just don't know how you particularly will react. We can give you some data about the 25 patients I've seen before you, but even still, they're not going to be the same age. They're not going to have the same comorbidities. So I think helping patients to understand that uncertainty has a huge role in all parts of cancer care, from diagnosis to treatment to survivorship, if there is survivorship, or even when to expect the unexpected. I mean, we probably have all seen cases of people who shouldn't have died but did, but at the same time, I can understand that that's a really hard message to hear. And even as you were saying about people living with cancer, trying to explain to people with non-Hodgkin's lymphoma that we may not cure that cancer, but they might live for 20, 25, 30 years with that cancer is something that's challenging for them to accept.
I think we often use the rubric of uncertainty to speak to, we on the provider side use it to speak to scientific kinds of uncertainty. I actually think, and I've seen a number of interventions that are designed to reduce patient uncertainty by basically giving them more information. And I actually think those have not been successful. And I really wish, and since you're from the NCI, I'll make a pitch, that we could test more interventions that are about learning more emotional self-regulation and working with providers on developing those self-regulation strategies. And I feel like that would get to me at what the underlying dilemma is for people with cancer, is how do I live when I'm not sure what's going to happen?
Sorry, we do have a program announcement on palliative care health literacy that's active. Just since you mentioned I'm from NCI, I want to give a plug.
Yeah, I'd like to comment that I think the uncertainty certainly applies to the biology, but I think as a profession, we should take the non-biologic parts of illness and make them certain. Those things that are fundamental to medical ethics, like autonomy and fidelity, keeping our promises, standing by our patient's side. I don't think there should be any uncertainty about those, even in the face of illness or biology uncertainty. Deborah.
Hi, Deborah Collier, Patient Advocates and Research. Thank you all very much. This was great. I have so many different questions. I'll try to keep it to a minimum. But language, I think, we're hearing over and over again is very important. From a patient standpoint, when you are diagnosed with cancer, you're dealing with uncertainty, no matter what. Okay, so it's also important to understand that control is a very important concept for patients because they've just lost control over their body and many other things. So whatever we can do to talk about what they can do that you can empower them for, because uncertainty equals fear to patients. Okay, it doesn't matter what you call it, that's what it is. And so anything we can do to lessen fear because they can control certain pieces of their lives is important. This also gets back to the C word, which is not cancer, it's cure. We use it way too often. It does not mean the same thing to people and patients as it does to the medical and scientific community. We need to stop using that word until it's what people think, which is they're not going to have to worry about this again. Actually, George Weiner and I are working on a series of blog posts about language and what the differences are between patients and the medical and scientific communities. Another word is palliative care, right? Real people don't know that word. So why do they think that that's end of life? Because someone told them that or gave them that impression. We need to stop that. What it actually means to a lot of people who understand, or when we're explaining it to them, they think about it as total care, right? Not palliative care. It's the total care for their whole life and how they can deal with having a disease like cancer. So things like that, we need to think about what is it from the patient's standpoint, and then how do we develop messages and tools for that. The other thing I wanted to ask, so I'm going to ask you guys to kind of comment on that, but and the other thing was on the PROs. Great concept. I'm totally on board and supportive of PROs, but they are more than just the medical side of life for patients. And we have to get better about quantifying the experience and the issues that people are facing, not just their symptoms. And I'm also wondering, the answer that I hear often is, we've got a portal for that, a patient portal, right? We know not many people are going to be involved in that. Even having to do it in the office, there are other ways to do that. There are companies like Emotive that's out of the UK that has a more of a push approach where maybe there's a question a day, or some other type of approach that can be texted or apped or whatever, but in a way that patients can accept, that can still get that information. So I was wondering how you guys feel about that type of thing too.
Who wants to answer?
I can address the last comment regarding the PRO. I think it's a very valid comment. It's the notion of having the systematic screening of PROs to facilitate patient care. It's relatively new in the sense that it's growing more and more now in cancer centers. And part of the driving force behind that is this value-based care that I very briefly mentioned, meaning if we systematically assess symptoms, we catch them at the right time, are we going to eventually provide better care for the patient? Not only are we looking at patient-level outcomes, but also system-level outcomes. Can we reduce visits to the emergency room or readmissions or length of stay, et cetera? So I guess the easy answer is we're at an early stage. Ideally, you want those algorithms available, or you want to be able to have algorithms that are very patient-centered. A patient going on a phase 1 trial should have a very different assessment from a patient who's 3 to 5 years after post-treatment for localized disease. And I think that's where you were asking, what you were referring to, that there's more specialized ways of doing this rather than having this sort of template that's somewhat generic, which I would agree. It gets at key symptoms and key needs, but we could do a better job at being briefer and actually more precise.
I just wanted to comment, and thank you, Deborah, for reinforcing that words do matter. And they matter in a number of ways, in a number of fashion, and sometimes they're further perpetuated by the media that's out there to create further misunderstanding. So that's a whole other area that we need to address better, but also to figure out how people like to receive their information. And then the last point that kind of struck me when you were mentioning that is that so often, as educators, as clinicians, we want to introduce all the new innovations, what's happening in whether it's cancer prevention or cancer care. But at the end of the day, if a person has never been exposed to it, how do we expect them to participate in it? And we just recently had one of our community partnership meetings where we were talking about the importance of matches for transplantation and that individuals of mixed ancestry may get left behind. And many of our community partners, especially those from the farm worker community, said, well, I never knew that. And if I don't know it, how am I going to help? How can I mobilize and empower my community? So it's really this trickle-down effect of how communication, of using the right words at the right time.
I'd just like to underscore one thing that you kind of alluded to. Ms. Collier, because I thought that we have had a really important discussion here about communication at everything from the clinician to the patient in the privacy of the clinic room to broad public messaging. And I would just like to distinguish that I do think that the field has kind of a confusing public messaging stuff going on. There's all kinds of stuff floating around. And to the degree that the field could align around some big things like on palliative care, for example, I think that would be very helpful. And I think we have to make sure that clinicians don't get caught feeling like we are trying to put words in their mouths, right? So there is this public messaging work that has to happen, and then there is the communication that happens in the clinic room.
Next, thank you, Dr.
George Weiner from University of Iowa. So to follow up on the theme of terminology in palliative care, I'd be wondering what the panel would think about the use of supportive care instead of palliative care to change the perception that it's not just about end of life.
So that has been an area of great debate in the palliative care community, and some cancer centers do call their palliative care team the supportive care clinic or the supportive care team. What has happened in some centers is that then becomes equivalent to palliative care if misinformation is connected to the term supportive care. So I think the problem is much bigger than our name. I think the problem is this idea of being afraid to talk about the potential of end of life as part of a cancer journey. And while changing the name to supportive care might buy us some time until people understand what we mean by that, I don't know that that's really the ultimate answer. The downside of supportive care is it's so general. It's a little hard sometimes for patients to really understand what it means. Same with palliative care, but I think our problem is bigger than the name and gets at how are we normalizing this as a normal part of a cancer journey and something that everybody talks about.
I would reinforce that. I am not sure that I think it's a bigger problem than just changing the name. You know, having worked at a big bone marrow transplant center for a long time, as I know your center is also. I mean, when I was a fellow, I would have patients crying because they were getting a pulmonary consult, right? Like they figure, they know when their lives are in danger, and we have to have other strategies than telling them not to worry.
Thank you. Next.
I want to thank the previous two questioners. I think you addressed my first question, so I won't go into that. I'm Christy Munger. I am a breast cancer survivor, and I'm also a human-centered designer. And I believe earlier in the panel, human-centered design was briefly mentioned. But I'm curious from each of you how you're actually integrating patients in designing your programs, in designing your patient-reported outcomes methodology to ensure that it's being created in a way that actually resonates with patients and using their language.
So for the patient-reported outcomes program that we are implementing at UHealth, we actually are following an EPIS model. It's an implementation dissemination model, and it's EPIS it's an acronym for Explore, Plan, Implement, and Sustain, I believe. I think I got that right. It involves stakeholders throughout the entire process. And we have a patient advisory board, and we drew from that patient advisory board patients to participate in the process whilst we were building this. And actually, we're replicating a system from my old institution at Northwestern, which is where we created this initially. I can tell you that we got excellent feedback from the patients, including ranging from, this sounds to me like you're about to give me bad news if you're asking me about depression and anxiety and fatigue, or all the way to, so how's my doctor going to deal with this information, or are they going to get back to me and give me feedback? And those are tough questions, and obviously we cannot facilitate that that provider feedback to the patient until the patient actually sees the doctor. But every assessment we do is aligned with a visit with the provider, so they would get some feedback at that point. But the quick answer is yes, we certainly have involved patients throughout the entire process.
Other questions?
I would just add really briefly that, obviously having community advisory boards and what that community means, could be people who are of that age group, people who are of that culture, or whatever your target is. But when we were developing a patient navigation system focused on fertility specifically in AYA, we assumed that the best navigator would be a young person who was their age, but fortunately we had a community advisory board that we could go to, and they said to us that is not what they wanted. They wanted a nurse, and they didn't care what age that person was, but they wanted someone who had the medical background, not someone who was their age or who had been through that experience. So, and I think that changes, we could ask them again in a year and they could have a different viewpoint.
I wish there were much more patient involvement in every phase, even though it's starting. PCORI is using patients. A number of people doing PROs work with patients. We've worked with patients very extensively at different things. And yet I think the continuing challenge is that patients who are in the middle of their cancer treatment, which is exactly when you want them to participate, that's when they're too overwhelmed to take another day and spend it with the human-centered design team. And I think that we need to figure out something else about that, because I think the human-centered design practices that come from the product development world, right, the IDEO, our patients don't have the time and energy to participate in those same ways, and we have to figure out what are the new meaningful ways that they could actually do.
In the last couple of minutes, would each of you give the couple of headlines from what you think the policy recommendations are? We'll start with Dr. Meade.
Okay, policy recommendations for communication. I think one of the areas that we need to be very mindful of is to continue to engage individuals and groups that are marginalized and are underserved. Thereby, our communications need to embrace them much further. So that would imply greater funding in that area as well.
Dr. Beck.
I'd say that the policy recommendation I have is really about embedding communication training in health systems and cancer centers so it can address the myriad different topics that have been brought up here, and do it in a way that clinicians see this as sharpening the saw in this area is going to be a necessary part of my career because the technology is changing so fast. And we need to have ways for them to learn that are built into their postgraduate world, their work world, instead of talking to them about the art of medicine, instead of talking to them about this is a nice thing to do. We need to make it clear through these policies that this is part of being a great clinician, is doing this work and renewing it.
Thank you, Dr. Quinn.
Particularly with regard to the adolescents and young adults, since we know what the spectrum are of issues that are relevant to them based on age, I think it's imperative that cancer centers or oncology treatment centers be prepared to address those, but not necessarily to have those people on staff. I mean, young people and all of us, even older people, we use technology now. So we can connect people through technology rather than having to have a whole host of people for what might be a smaller group of your patient population.
Thank you, Dr. Penedo.
I would agree with Dr. Beck. I think embedding it into the health system as a required competency for providers so that there's competent health information, communication, and exchange with the patients is necessary.
And Dr. O'Connor.
So I think my main message is normalizing palliative care is something that's helpful throughout the entire continuum, and therefore we need policies that address workforce and also public awareness to really address a lot of the misconceptions about palliative and end-of-life care.
And there were two other things on my list that I heard from your talks that I think need to be included. One was culturally formed framing that Dr. Penedo talked about, and what Dr. Back talked about to be able to respond in an encounter to the level of literacy that you're seeing. That training, I think, needs to happen as well. So please join me in thanking a wonderful group of panelists, Dr. Cathy Meade, Dr. Anthony Back, you know who they are. Thank you.